welcome everybody to another episode of the MyData webinars. Today is an international one with representatives from several countries. As usual, I'll quickly go through an introduction showing some topics about the MyData organization, and then I'll hand off to my guest speakers. And with that said, quickly go through these MyData key items. As you certainly know, personal data is everywhere. And today we are focusing on health data from several countries. This is my favorite chart about personal data in the digital space. So in the past, we started out with a very API-centric approach, which was pretty chaotic at these times. So right now we are more in the world of the big tech companies with all these servers. I call that the data middle age. The previous one was more data stone age. But the objective of MyData is obviously to move towards a human-centric approach and based on privacy by design. And so we are somewhere in the transitioning phase. And one important role in this scenario is actually the role of the MyData operators. And it's some type of data fiduciary, because if you go into digitalization, it is rather difficult for the individuals to handle this sometimes pretty complex technology. So somebody has to do that for them in their own name. And that's more or less the role of the MyData operator, who is acting as a data fiduciary. So the data still belongs to the individual, but it's operated by somebody else in the individual's names. So for those of you who are interested, you can check out the link. You'll find more information there. With that said, quick introduction of our MyData Zurich hub. We have been founded in 2019. We have a very close cooperation with the Swiss Data Alliance, and we are focusing on hands-on activities. We are also present on LinkedIn. I'll show that in a moment. And I'm very glad to welcome Jonas Bertschi in his new role. So here you can see our leadership team. Andre and myself have been doing that since the beginning. And Andre Gollier and Jonas are both representing the Swiss Data Alliance. And Jonas, welcome and thank you very much. Would you like to say a few words about your role in the Swiss Data Alliance?
Yes, we're actually in a very interesting phase right now because it's in the Swiss Parliament, the secondary use of data, that they want to make a new law concerning that. And this was brought about by Swiss Data Alliance, in part, especially through André Gollier, who was able to meet up with some parliamentaries. So that is very exciting. Also, we are trying to find ways how to expand our network, go into the whole field of data as a commons. Some of you might perhaps know Elinor Ostrom. So that is a specific topic that we're thinking about right now. For me, it's rather fresh. I just started in September, so I'm still getting into things, but it's very exciting, and I get to learn a lot of new things, which I always like.
Great. So thanks for joining, and we will certainly do a separate session about this activity. The term data space is cited quite a few times in this law, so there's quite a bit going on here in Switzerland, finally.
Absolutely.
So with that said, a quick heads up where you can find us. We are mostly represented on LinkedIn. In LinkedIn terms, it's a company. So it's MyData Zurich. You'll find the upcoming events there, and we have a sub site which is more towards local data spaces or open government data. So we have events on two sites or on two places if you're looking for that. And we also have the YouTube channel. We are usually recording our sessions, and we are also producing short versions in the future. So there's a separate channel with our own name. And we have also playlists by topic. So if you want to focus on a specific topic, you can choose the respective playlist, which you can see here on the side. With that said, we have a few upcoming events which are already confirmed. We have one early March about data literacy from a representative of the city of Zurich, who is the evangelist in this topic, very interesting person. Then mid-March, we have somebody from Roche. Damian Page is the head of healthcare data ecosystems, and he is focusing on real-world data. So they are really looking to get data in addition to the running studies. And the third one, which is confirmed, it's quite different. It's more in the open government data space and smart city space. It's Kaisa Wendt from Tallinn, who is researching in this area and is doing her PhD thesis. Then we have a few more things, as I mentioned already, that's this famous relaunch. So Jonas, I'll catch Jonas for that to plan a separate event. Then we have data literacy events in the plans. We have something with MyData Zurich and about digital billing. So that's in the works, and as soon it's confirmed, you'll find it on the events. Then for those of you who want to support MyData, you can of course join. You can in any case sign a MyData declaration. With that, I'm already moving on to today's program. We have 4 guest speakers. Thank you very much for joining us. And after my short introduction, Mikael will tell us something about the cultures, and then we will hear from the respective countries, Denmark, Sweden, Switzerland, from our guests, and then a short discussion. And we are planning about 1.5 hours. For those of you who are very interested, we are available for unofficial questions, but we'll turn off the recording somewhere around 8 in the evening today. And with that, a very short introduction, who is going to present today. You're welcome to add a little bit more to your own CV. Mikael Rinnetmäki from Finland, the founder of Sensotrend, collecting diabetes data. Then Jan Leindals from Denmark, also offering diabetes services. Then Fredrik Linden from Sweden, consulting in the healthcare sector, and as I have learned, also in the energy sector. And Markus Gnägi from Switzerland, offering diabetes services here in Switzerland. So this is my pretty short intro. Thanks to all of you for the time. Mikael, floor is yours.
So as Peter said, Sensotrend collects diabetes data, so we connect with dozens of medical devices and wellness trackers, and we take the data together and derive actionable insights out of that, so people learn how different things affect their blood glucose and then learn to adjust insulin better and get better treatment results. But my key point here is the different aspects of MyData, and especially within Europe, and different kind of emphasis. So as previous presentation, Peter said, okay, it's privacy by design, and privacy seems to be the key point in German-speaking countries. It's mainly don't store my data, don't process my data, don't share my data. Of course, these are a bit aggregated, but this is how it looks like from the Nordics. And the Nordics, the point of view is much more about give me my data and let me use my data or data collected from me, and let me share my data with the parties that I trust. And I know that Jan is somewhere in between, but I still include him in the Nordic countries. So I kind of see the history of this, and especially in Germany, you have a big history of data being misused by the government to target people with different religion or ethnicity. And also after that, in the East Germany, Stasi spying on people. And I feel that personally too, when I share my diabetes data, if somebody just makes a judgment on me purely based on the data, I kind of feel that it's an invasion to my identity. I want to be able to explain, okay, this is the data, but that's just part of me. It's not whole me. So I do get that point of view, but still in Finland, it's much more about, and Nordic countries, much more about reuse of the data and really my involvement in saying, okay, I want my data to be used in this way and that way. And this is kind of similar to what's happening in US. They have the right to repair movement, initiated by some farmers who bought new tractors and other machinery, and then the machine got broken and they found out that they are not able to fix the machine themselves because it has a proprietary data connector and you need an authorized repair person to come in and repair it, and then they can charge prices that the farmers think are not fair. So there's the kind of right to repair movement in the Nordic countries. It's mainly the MyData movement that drives the same topics. And from diabetes side, there's a global movement called Night Scouts, and that's a really nice example of that. So in 2013, some parents of children with diabetes got access to information on how to get data from continuous glucose monitors that measure your blood glucose each 5 minutes. And they could access that data programmatically, and they could equip their children with a smartphone that reads the data and then transfers it to the cloud. So whenever the child is in school or playing with friends or something like that, it's just a flick of a wrist for the parent to see the blood glucose on their smartwatch. And that's a really great peace of mind for these parents. And it's gone further, and now there's also automated insulin delivery apps produced by this community. So noticing or controlling the insulin delivery from an insulin pump based on the glucose sensor readings. Anyway, back to this and health data. I do know that there's this electronic patient record initiative in Switzerland and also the DIGA initiative in Germany. And especially the DIGA initiative seems really lucrative for app vendors like Sensotrend. And kind of I feel that having all health data in paper format and in isolated locations helped Germany to kick off this big initiative, because every time we are talking about healthcare digitalization and improvements in healthcare, Germany was somewhere in the bottom, and they got really embarrassed and I guess also afraid that no other countries will evolve much better and they will achieve the benefits of efficiency through this data. And they were able to put many millions of euros into this initiative. But in the Nordic countries, in Finland, for instance, we have had the electronic patient health record since 2010. And well, since 2010, we have had a version where you can view your lab test results and you can see your health data and prescriptions. But now we are getting also app access to this data. And it was supposed to come live beginning of December last year. It's been delayed a bit, but it's coming any day now. So that's pretty exciting that we actually get patients getting apps, and there will be an approval method for those apps. So somebody goes through, okay, this is a nice app and so on. But anyway, we can have basically any app taking our health data and, for instance, genome data from 23andMe and activity data from these trackers and combine that data and make meaningful outcomes and insights out of that. We also have the personal health record. That's a separate part of this Kanta system. And this has been from the start purely for the wellness apps. So this is mainly for apps that people use. And this is for data that you as a citizen collect. So all these wellness trackers and also health data that you collect in your own personal life. And if you look briefly at the global scale, we know that we are in the start of the new industrial revolution. The first one, there three have been already: the technical revolution and the technological revolution, and then the first one industrial, then the technological, then digital, and now the next one will be that of data and AI. and these images are drawn by the AI. And currently the big problem for Europe is that most of the data goes to West Coast US for some big tech companies, and they use that for commercial purposes, and their AI proceeds really fast. And the rest of the data goes to China, where they have mega apps that have social media and banking and payments and everything. And then they use that for social credits, and also the AI progresses really fast. And now Europe is wondering, what should we do? And in at least the EU part of Europe has chosen the really MyData centric approach already with the ancient GDPR, but now with the big five regulations, so Data Governance Act, Digital Markets Act, Digital Services Act, Artificial Intelligence Act, and Data Act. Those are all coordinated, and the purpose of all of these is to really get data flowing and processed within Europe, so that we also can get our AI to evolve through that processing of data. And it's not just the legislation, there are also industry initiatives like Gaia-X and in the International Data Spaces Association and so on. So kind of balancing the approach from the politicians. This is actually what companies would like to do. And I'll end here and really tell our Swiss audience, please join us in the European thinking, where actually the data subject should be in control of how the data is processed. And we still need to have the data available.
Very good. Thank you very much. That was indeed very interesting. I have quite a number of things which I could add, but I'll do that later in the discussion. But that was really very helpful. With that, I would like to proceed to Jan for our next update from Denmark activities. Very keen to hear what you are doing.
Yeah, my name is Jan Leindals. I'm from Denmark, and I have I'm building a personal IT infrastructure to share personal data from diabetes and lifestyle management. That is self-monitoring devices like Mikael, like glucose sensors, insulin pump, wearables, and it should be shared with clinics, researchers, and industry. The first slide here is to see what is data, how data collected in Denmark. It starts when you are born. Then you get a CPR number, which is like a social security number. It's your birthday and followed by 4 numbers. And everything you do is connected and linked to this number. Every time you go to the GP or the hospital, it would be a record. So it has been there for quite a long time. It's only public health care data that is inside here. Because in diabetes, all these medical devices, they are collected from your own source and now shared with the industry's data websites or cloud services. Everything you eat, you can have that data, but it's in your own diary, or you might collect the data from other sites. And the exercise, it's also about from the tech industry, wearables and smartwatches, etc. Just to give you an idea of this social security number, CPR, in Denmark, it has a special classification. It's not a sensitive data, but it's the data is used, so it can relate to highly sensitive data. So it's protected. Just a little history of this number. The unique number, it was introduced in 1968 for making faster tax payment. And now, as I said before, everybody gets it when you are born. You don't need a name, you just get the number. And it's used by the government and also private companies that is regulated. So in finance and tele sector, they also get this number, but you don't use it in a store. So it's only those companies that are regulated by the laws in Denmark. We also link all these data together for statistics. So we have a central database with our CBR number. So every researcher, they have access to every citizen's data, but it's in a protected data rooms. So they don't just get direct access, but they need to make an application to use the data. But the citizen only can view his own data. So we have a lot of websites and apps where we can see our own data, but we cannot use free flow of data. It was just like Mikael said, we want to reuse our data. So I cannot get my data out to other service, but I cannot not share my data as well. The collection of data, this is just some examples where I can make digital message to my doctor and to the hospitals, and all labs results, they are also fully digitalized. Even if I go to my DP, they send this into this central database, and every prescription I get, this is also stored in this central database. So the municipal, which is typically the payer, will also have access to all these kind of data. So all these things are linked. But again, the diabetes data, this is sort of outside of this. So all these data, it's still in private companies, and they are not gathered together. This slide here is saying, well, who will benefit from the knowledge of the data? The slides I just showed you before, that was from this Danish healthcare data, where they actually want to have investors into Denmark, because the knowledge is used for clinical research and of course patient care. It's also doing for other research and the industry for making commercial products. But it's not no MyData. The clinic, there's no reuse of the data for service. The research, I don't know where I can find research, and if I can, it's in behind a paywall, so it's not open access. And the industry who use my data, I do not get any compensation for any value what they produce of the data. So I don't think that I'm in control here. So if I want to share it, my data, I don't know who actually use it and for what purpose. So I see the challenge here in Denmark. The problem in our healthcare sector, well, the citizens, they are not truly empowered. And just earlier today, we have this European health data space discussion. I think it's very similar. What is in this proposal, what we actually have in the Danish system, it's not MyData compliant. What I think we need to change is that in Denmark, we have all these system integration, but we need to change it to a person-centered data integration using these trusted data intermediaries. So we can have the person in control. And I think that was all about it.
Thank you very much. Honestly, I'm really impressed. Denmark is certainly much further than we are here in Switzerland. So that was really very impressive, I have to say. As I said, I'll add a few more things, but before I do that, I would like to pass on the word to Fredrik for the Swedish view.
So thank you, and yeah, as we said, my name is Fredrik Linden. I'm the co-founder of MyData Sweden, and I'm currently taking part in a project by Vinnova, the Swedish innovation agency, that's called Data for Diabetes, your virtual pancreas. it was a close call, and basically similar to the previous presenters. It's about primary and secondary use of electronic data, and running a pilot to demonstrate how this can be done in Sweden and the Nordics for diabetes. Our outset was that we want to hack before the summer last year, and basically we said if not now, when? And we actually won that one. And our basic thought was access to data for actionable insights. It needs to be lawful, it needs to be scalable, and it needs to be verifiable. And this is not only for the individual, but it also are for the organizations using this data, because you cannot just take decisions or base research on any kind of data. You need some kind of verifiability of it, and that it's lawful all the way through the chain, which is impossible to follow up on today. Our patient at the time at the hack, it was Annette, actually from Denmark. She's got type 1 diabetes, and you've heard Jan's presentation, and that's the situation that she lives in. Actually, she's done hacks of her own, connecting her glucose meters and her automatic dispensers and so on. But there's a lot of data points to keep that sugar under control, basically. This is just a mock-up, but we need to follow medications, activities, biological, environmental, food, obviously. We, in the hack, focused on the food, saying that we'll use a visual recognition tool to actually automatically calculate what's in this nasty sandwich here in the picture, so that her other tools can feed her the right amount of insulin as she goes into this, based also on everything else that she's done that morning before lunch. But not only that, you need to have all of the other connections. Here you have different healthcare institutions, different the Swedish e-health agency, and so on and so forth. So creating the ecosystem to share data, we called it the Nordics data, the data marketplace. We went quite far there to be in the face of the regular market here, where just talking about a market is dangerous to some people, and we understand that is a difficulty, but we also understand that this needs to happen. As Jan pointed out, it needs to be integrated around the individual and not the data sources themselves, and it needs to be visualized so that it can be reused. We have the data, this is more technical view of this decentralized app. And this is now, we've gotten into the project more, and some of the feedback that we've gotten is, whatever you do, don't give us another app. It needs to be workable in the national or regional settings, and it needs to be understood. And this is where the regulatory compliance in the data intermediation is so important. The verification and how this all is governed. We've also come to the point where we are discussing the value flows in the data marketplace. So the business modeling, trusted onboarding, pay to use, obviously subsidized by data sharing, data flows. There needs to be some transactional costs here, but also agreed value flows of larger findings from the research institutions, from the public health care, and so on. So there are several components to a ecosystem business model for diabetes data, but actually for healthcare data in general in the end. And also data beyond healthcare as we think of it today. We're a team of people which are in here. You recognize some of them as being very active in the MyData space. We do have Jan Hellman also, a diabetes doctor in Sweden at Uppsala, and Professor Harriet Moberg, who's quite involved in this at the Karolinska Institute. So there are guiding lights on the professional side, and then of course the focus being on the patients and how to govern this, keeping a patient's perspective and not faltering into the public healthcare or the Nordics or the medicine providers or the advice providers, but really staying focused on the patient.
Thank you very much. Very impressed. So in the discussion, I certainly want to know how far you got. But before we jump into that, I would like to give Markus Gnägi the chance to present his view. As he has a long track record in Switzerland, as I learned. Markus, the floor is yours.
Yes, that's correct. I'm for more than 20 years now in the digitalization of the healthcare sector. That started in 1999 with quite simple things, and I have seen all the development through this time in this sector. I would like to show you how we would like to improve diabetes care in Switzerland, and I do this from a perspective of an entrepreneur, of a startup company that tries to do business in this specific market with the diabetes service. I would like to quickly introduce you to the situation of diabetes care in Switzerland, which is the problem. Then talking about meaningful use of data, which is the part of a solution. So digitalization will indeed increase quality of care in diabetes in Switzerland. And then I would like to show you the specific framework in Switzerland. We have heard how the world looks like in the Nordic countries, and I will show you how it looks like in Switzerland, like quicksand. And I would like to tell you how we try to handle this complexity with our service and our product. The situation of diabetes in Switzerland is, as you can see here, we have about 9 million people living in Switzerland, 500,000 diabetics, of 5 billion of direct cost of this chronic disease, with a lot of costs of secondary diseases additionally. We are faced with a lack of general practitioners, so a lack of 5,000 full-time equivalents in 2005, a low reimbursement for diabetes care, so opportunity costs for general practitioners. And according to the guideline, which is international, of course, we should have 1.5 million consultations per year. So a huge requirement or a huge need of medical resources to fit or to fulfill the guideline requirements for a good diabetes care. So what is the challenge viewing this situation is there's an improving of the care process is required. The throughput has to be much higher. There's an industrialization needed, and the only way you can do it at the moment is by using more data. So in order to increase the quality of care, you absolutely need to somehow handle or deal with data. The goal, of course, is improving prevention for secondary disease. This is generally accepted, or is in line with all political goals, is in line with all goals of all stakeholders of the system, and is independent of the healthcare model. So this is the general situation. What we now do as a solution is a decoupling of the resources. That we say, okay, we can't bring all diabetic patients to medical doctors. This is logistically impossible. So let's decouple the resources, let's decentralize the monitoring process, and just use the findings data, send it to medical doctors on their screen directly. It's even thinkable to establish a center of excellence that pre-analyzes data and find patterns, provide clinical decision support. We are not yet so far. This data exchange, which we try to establish now in Switzerland, would also allow interventions on demand, kind of alarms if necessary. Well, for you, maybe this looks quite simple and obvious and nothing special, but when you have a look at the regulatory framework in Switzerland and the actual situation, then you can maybe better understand why it is quite challenging to establish this kind of data exchange and a health record for diabetics in this regulatory framework. First of all, when I hear the story from Denmark, I'm quite jealous. Here in Switzerland, we do not have anything, even not the EID. We lately voted in Switzerland to introduce in a fully democratic process, so a vote, and Swiss population denied to introduce an electronic ID, which must be surprising for you in the northern countries, but it reflects a bit what Mikael mentioned in his speech. There's a different cultural approach, and we indeed reject it. Of course, we do not have any kind of electronic health record available. We have discussions. These discussions are as old as I'm in this market active. So for 20 years, we are talking about how we could do, and stakeholders are really fighting for their interests, and we still don't have the electronic health record, and there is no, let's say, outlook that it will be upcoming in the next years, maybe in 5 years, maybe in 7 years, but everything is still open. So this is the regulatory framework. What you see on the sketch of the left side is that, of course, as in Nordic countries and in all other countries, patients are using their devices. They are uploading data to different cloud solutions, industry-driven, of course. So the situation we heard in the speeches before is indeed the case. The solutions are helpful, easing diabetes management for these people, but it is not possible to share this data with healthcare providers. By law, they are not allowed to access data. So therefore, we need this clearinghouse, data clearinghouse that we are establishing, gathering data from the patient-centric, of course, to the record, and medical doctors, care providers have legally compliant access to this diabetes record. What we observe is that there's an increasing gap between what the law allows and what everyday life shows. So more and more medical doctors indeed get access directly to the cloud data of the patients. They have the credentials, they go in the browser, they open the data just to see the data of the patients, which is, from a legal standpoint, not okay. But it's what happens in everyday life in Switzerland. Well, the quicksand thing is that we have, on one hand, no digitalization, no data records established in Switzerland. We have transformation of the healthcare system on one hand, and on the other hand, we have, on the technological side, the transformation as Pete mentioned, from Stone Age to, I would say, Middle Age for the moment. So everything is moving, and how can you now design your service in a way that it will fulfill legal requirements on one hand and user requirements, usability, for instance, accessibility on the other hand. So this is a real complex problem, a conundrum to find ways how we design finally this diabetic solution in Switzerland. And these are our findings and our experiences from the last 3 years during which we try to establish this diabetes record in Switzerland. So we know that there is a flow and there is quicksand. We have to live with that, and we cannot influence the flows. This is an important aspect. We're a small company doing something very specific, highly focused on what you have seen before and nothing else. So we do not have the power to influence any political thing. We observe the flow, of course, and we fulfill all relevant industry standards, GDPR, CE certification, and so on. This, of course, we have to do, but we don't have to be proactive. It's not that we have to be better than others do. And this was a mistake we made at the beginning of our start of the company. We tried to fulfill all requirements that maybe would appear once in time. This led us to a very heavy and strong technological stack and a solution. So nowadays we say we design our service, including privacy, according to users' behavior and self-declared requirements. I mean, if people like to handle their data in a certain way in everyday life, we design our repository solution in a way that fits to these requirements, and we do not any longer try to fulfill all, even future requirements, what could pop up later by government. Of course, we remain patient-centric, but again, we are living in a world completely different from what we have seen from Finland, for instance, or before in the speech from Denmark. There is no definition what a health record should be, how it should look like technologically, and what patient-centric design could be. So we are moving now with this diabetes record in this flow, within this flow, and we are focusing on the aspect that we say it's data that will improve quality of diabetes care in Switzerland. And again, there's no differentiator in advanced compliance. That doesn't help anything. These are our experience and findings from Switzerland in this very specific legal framework and surrounding, but point of view disease, point of view behavior of patients, diabetic management is absolutely scientific, is the same as in your countries as well. Thank you very much for the time.
Thanks a lot, Markus. That was really very interesting. I knew it in advance a little bit. Of course, we had some conversations. I would like to add 2 or 3 things since they were brought up. First of all, the electronic health record in Switzerland, it's right now just getting off the ground, and it's a system which is designed as a digital archive of PDF documents, more or less. So there's no structured data in there. And there is a big complaint about how long it took and how expensive it was and how useless it is because there is no recognized added value, neither by the patients nor by the medical community. So that's the big criticism about it. And people start to realize if they want to get it off the ground, they need to do certain things. For example, the onboarding process is extremely painful. So you have to show up in person. So it's an identity approval process. And people start to realize as long as it's complicated or even very complicated for the day-to-day user, it just won't happen. So that's happening right now. Technology-wise, they had some problems. So there were way too many providers. So we had different technical platforms. So that starts to reconcile for the time being. So one of them has dropped out already. So there are 3 remaining. It's the Swiss Post is operating the main platform. The pharmacies have their own platform, and the medical doctors have their own platform. So there are certainly certain interoperability issues. It's more or less an exchange of PDF documents. And what we need to make this thing a success is certainly easy access. So right this morning, we had a call with one provider, and to my knowledge, it's the first one who are able to provide an app to access that. And that's what most people would expect today. So it appears there's an app, and of course, it's not compatible with the other technical solutions. So that's where we are right now. And talking about the digital identity, it was voted against it, but the effect was that 6 political parties issued a motion right the next day after this vote failed. And right now there is quite some activism there. It's a new version of digital identity, which is expected somewhere in 25, 26. And the criticism of the past was actually it was way too commercial. So people wanted to have that issued by the state, by the government, and not by a commercial company. So that was one of the failure reasons. And the other reason of the failure was that the government totally underestimated that it needs a lot of communication and education, since that was one of the first digital solutions which was the Swiss population asked to vote about. So that's a little bit the background of this thing. And the new world will be hopefully compatible with EU, and it will be based on self-sovereign identity topics. And I will share in the description of this video a prototype which is currently being produced by one of the main providers based on the self-sovereign identity technology and concept. So people started to realize we need to work upon it. And the last word is about these DIGAs. We actually had one webinar here on this platform about the DIGAs. I'll share the link in the description of the video. And Germany is quite active. And Germany, with the former Minister of Health, I think they launched more than 30 laws and a lot of funding, about 4 billion of funding. So they were quite progressive. Unfortunately, with the new Minister of Health, most of these things have been stopped. So I don't know where it's going there. So that's a little bit the situation which I'm following so far. And of course, I have tons of more things which I can talk about, but I would like to open the floor for questions and discussions. So are there questions or points which you would like to ask or to bring up for more in-depth discussions? Floor is open. Just open the microphone and join the discussion.
I'll start with the electronic identity. We of course have it in Finland too. And in early 2010, or was it even the first decade of 2000, we also had the government-backed initiative to make that happen with smart cards. Like it was actually 2004 or something like that. But that failed. And the learning has been that when the public sector tries to do too much by themselves, the initiatives are tacky, take long, and don't succeed. And the ones that succeeded in Finland were the initiatives driven by the banks and the mobile operators. But nowadays, when actually the private side showed that this is the way it can be made happen, and these are the actual business cases that you can build on top of that, then the public side can also emulate that and then join the party. And now all of them are cooperating in a really nice decentralized distributed architecture.
Yeah, in Switzerland, we had a sort of a digital identity a long time ago. I think the difference there is in the early days when the connectivity was not yet there, it was on a physical token. And I've been using that for more than 10 years. And if you have a physical token, you always have driver problems. And with the transition from the physical token into a mobile network or data center based identity, which you can call up with your mobile, a lot of things improved. One thing which I would like to add as well, I'm very impressed about the approach of Denmark with the social security number. And we have a similar thing in Switzerland. And believe me, there was a big discussion. It was initially targeted to be really a social security number. You only got it assigned when you started a professional career, so starting earning money. So it was not assigned at birth. But the even bigger discussion was about the profiling. Once you have one single number for everything, you can be profiled for pretty much everything. So this discussion is still going on, but we have a very recent development. So nevertheless, despite all these concerns, it has established as sort of identificator, not an identity, an identificator. And now it's being opened. It used to be called ZAS in Switzerland, Zentrale Ausgleichsstelle. So that's very clearly targeted towards the pension system. But now it's called UPI, Unified Person Identifier, which gives an indication what the future purpose of that one is. So they have realized they need something like that. But it's not an identity, it's just an identifier. So that is also something what people need to learn when they move into this digital world. Somehow you need to identify yourself.
Well, maybe I need to raise my hand and excuse myself for the failures in Switzerland there. I tried in 2013, 14 to say, don't do this. It's the end of the line already. I was part of pushing that to have an interchange of data at all in Europe. At the time, it was the best technology or the technology, the pervasive technology around. But I'm happy that we're in a room now where everybody understands that it's a dead end and it cannot happen that way. I think Mikael's comment on the business model or the banks and the telcos driving this, it cannot be too much of a public sector initiative to drive this. It needs to be driven by us as citizens, patients, and consumers, as these identifiers are pervasive to our entire lives, not only healthcare or security and so on. And that's why we need to own them, control them, and for it not to be an organization to organizational exchange, but in organization to individual to organization. I was part of creating the problem. I'm trying to be part of helping to fix it as well.
Markus, anything to add? You know this situation for 20 years.
Yes, it's a long story indeed, and what we heard is correct. And we kind of lost patience and started diving and focusing in this diabetes case because the need of this data exchange between patient, real world data and care providers is key. This lack is decreasing quality and quality of care in diabetes in Switzerland is really bad, and no stakeholder, even medical doctors, pretend that it is not the case. So the problem is visible even on the economic side. You see the impact of secondary diseases. The costs are enormous. And digitalization is available, and we are kind of stopped or embarrassed to open this data flow between the partners in this system. And when we are now in the market with the system, and Mikael knows very well how hard we are fighting to establish the diabetes dossier, let's say that the criticism is still very strong, even though you have quite strong arguments for digitalization. And what is interesting that it is much less a problem of privacy or data itself, but it's you know, it's a game changer in the business models, in the care model, healthcare model, in the reimbursement systems. That's where the problems indeed and the resistance indeed is. So patients are willing, this is not the problem, they're handling their data every day, they need it, they think it's absolutely meaningful and helpful, but the care providers are actually the problem, and politics is not influencing things in a positive way. So it is indeed hard fighting, and it is frustrating what we experience actually in Switzerland.
Actually, what you're bringing up is a good point. So that the current tariff situation in Switzerland is actually prohibiting any sort of innovation, because we know that from discussion, Markus knows it very well. If you try to introduce such a solution to a medical practitioner, the first question is usually, to which tariff position can I book this activity? And that's where the whole discussion fails.
Stops. Indeed, yeah, right.
Did COVID help at all? Because I would say in majority, large part of the world, before we used to think that no, let's say video consultation, that's not the same as meeting face to face in an appointment. We don't reimburse it the same way. But when COVID hit, all the perception and interpretation of the legislation was changed. So, hey, of course you can meet through video same way as you can in a physical room. So did that happen in Switzerland?
Markus, do you know a little bit about the virtual consultations?
It happened.
Okay.
Indeed, but it was not reimbursed. So it is not established now in the tariff system, but it opened these gates to use cloud data. For instance, I know from a lot of medical doctors that had patients at home, pregnant women, type 1 diabetes. You have to care about them. They can't move with the public transportation just to see the medical doctor for a small problem. So they started freely exchanging data, giving access to their cloud data. This was really required. And that boosted the thing indeed a little bit.
So if you're saying cloud data, was that an existing closed cloud platform, or was it they just uploaded all their documents on Google Docs and sent a read link to the medical doctor?
No, this is, Mikael knows much more about this, but people with diabetes send from their devices data to the manufacturer's cloud. Then they have it on there, they can share it, they have it on the handy, and they can give with their credentials, of course, access to third parties as care providers. And that's what they started to do. And from a legal point of view of the care provider, it is prohibited. You are not allowed to use this kind of data. Hospitals are especially critical for this use, while cabinets just do it. And the industry provides more and more direct and easy usable system. But since there are different products in the market, as Mikael mentioned, for medical doctors, it's a problem to handle all these different devices. And that's why they don't do it, especially type 2 diabetics. With type 1, of course, the care is okay, is good. But type 2 is the huge mass of this 500,000 patients in Switzerland.
I would still say type 1 diabetes is the perfect example that you should bring to the electronic health record system, saying that PDF documents don't work. My continuous glucose monitor outputs 288 different readings per day. And if I would need to analyze that from PDF documents, that's just totally insane. We need more fine-grained granular access to data. And HL7, the health level 7 standards organization, realized that already in 2008 or 2009 and started working on HL7 Fire. And that is really concentrated on really fine-grained data elements and not documents outlining, for instance, the procedure and so on.
Fredrik wanted to say something.
Yeah, on the topic of reimbursement, it actually happened already in 2017, I think it was, starting reimbursement for distance monitoring and so on. And what we did in Sweden, we halved the reimbursement as we opened up to let it happen. Then a couple of years later, we halved it again, and it's still a working model. For both the providers and definitely the patients. Obviously, we also started sorting out which are the diagnoses, what are the protocols that are allowed to be reimbursed for distance monitoring and so on. So not everything is being reimbursed, but it was first cut in half, and then cut in half again, and it's still working for the providers. But also curbing the costs by saying we're not going to pay for anything. It needs to be something that we can prove is useful to be done at a distance, which are quite a few.
So if you're saying reimbursement, that was specifically for any of a specified sort of digital treatments?
Yeah.
That's missing. So in Switzerland, they have a very unfortunate situation. So our tariff system should be reworked for many, many years, and the whole process has been blocked for the last few years. It was a real fight, you cannot say it otherwise, between the medical doctors, the different branches, and the insurance companies. Even among themselves, the insurance companies were not in agreement, and it was an accepted fact that it needs to be reworked because of development of medical treatments. But again, it was a discussion about power and funding, and so it was really blocked. I think very recently it has been unblocked, and our Minister of Health, I think he have set a deadline by when they have to provide a solution. I would assume that it would be commanded if they don't do it, but this, of course, didn't help to progress the situation. Okay, Jan has a question.
No, it's just a comment about this reimbursement. In Denmark, we have a lot of issues. Who is going to pay? Because the hospital, they are sort of in what we call regions, and if they say it's a treatment is needed, then they have to pay. Else, the municipal has to pay, but they do not agree on that. So it ends up that the patients do not have access to these medical devices, and some of the manufacturers will not sell them as a private ones. I know that in Sweden you have everyone who has type 1 diabetes who has access to this technology, but in Denmark you still have to get your doctor to say that you need this, but it's about cost every time, because so we still have this problem in Denmark because we have a political discussion who's going to pay.
Yeah, that's another thing in Switzerland. We have if different sort of payments. If it's a stationary treatment, then within the hospital, I think the canton pays half of it and the health insurance company pays half of it. And if it's a non-stationary treatment, which is increasingly the case, which is desirable, then the canton doesn't pay anymore. So it's fully paid by the health insurance companies. It's a pretty asymmetric situation. And with the effect, since the canton doesn't have to pay, there's no incentive to improve the situation. That also has been a discussion for a very long time. And also quite recently, I think it has been unblocked. So they realized they need to make it more balanced to improve the situation. So we have this discussion as well. So Markus, do you have a question?
All these things you're saying is that that is what I mean with this shaky ground on which you build a business. I mean, we are doing something quite simple. We are collecting data that patients are uploading in a shared medical record, and we bring the result on the screen of the medical doctor in this patient context. So we do technically something quite simple. I know it's not that simple, Mikael. Of course, it's not that simple, but still, it is not rocket science. But what is around this solution, this discussion we just led, is crazy, isn't it? And there are patients out there, and it is obvious that care could be improved, definitely improved. Cost could be cut. Quality of life for patients would be better. Technology is there, medtech devices are there, everything is available, but we cannot find the fit between the different stakeholders in this system. And this is really frustrating on one hand, but on the other hand, what we can see is that we get more and more attention to this solution. So with this diabetic case, we show that digitalization and data is a value, has a value, it has an effect on healthcare. And but of course, for a startup in which you also have to convince investors to continue to invest in that, it is sometimes really demanding to do the job.
I know. Jonas has a question.
Yes, it's or rather a follow-up. I think the situation in Switzerland, it's really, perhaps it's a question of culture. This is following up on what Mikael said at the beginning. Data protection is what everybody is clamoring about. And again, we saw it with the electronic identification. It was always the topic of data protection. And this is perhaps a question to you from the Nordic countries. Why is it different? Is it just a question of history, or do you see certain decisions that have been made in your countries that helped, or how did the popular how did the normal people start thinking about this differently?
Most convincing argument I can think of is that we have not suffered from any major misuse of the data. Sometimes the government is inefficient or something like that, but they have never mistreated us, so we kind of trust them.
It is a trust in government, huh? Yeah. Okay. How about Denmark?
And also now we're at a point where the elderly do not accept the bad service or availability that has been given by the public health services before. They are expecting to do this easily as they do their bank work, or they order their airplane ticket to Mallorca or whatever. So there's also now a pull, a demand pull from not only the diabetic community, but also the elderly patients, which are in need of better accessibility service. To give you a bit of hope there, Marcus, I think you should take Mikael's picture of the US on the one side and China on the other side, and then Europe with a green question mark, and say, yeah, this is a big opportunity, and this is what you should present to your investors. We can make this happen. We need to make this happen, and we need to strike that balance, which is not there in the US and which is not there in China, but we have an opportunity to harness that one. I think that's a good picture, Michael. Thanks.
Yeah, it's a very good narrative, also, I think.
Jan, Denmark's view?
Yeah. I think if I should add something from Denmark, we also have this trust. I think this is built on a welfare system where we have all these taxes. So we pay for everything and we expect something in return from the government. So I think our situation is more different. We pay taxes about 50%, and I know that if you're in a lot of money, you might move to Switzerland because you don't pay taxes. So I think the taxes here is have a lot of saying how you are trust in your government.
And
Very
in
good point
Denmark,
as well.
in Denmark, if I'm right, you only have one single health insurance company, something like that.
No, you just pay by the tax.
It's the government.
So it's a government.
So
I
that-
don't have no insurance. I can have an extra insurance to get up to a private hospital.
Okay.
But else I'm covered by my tax payment. So even if you come and visit Denmark, you will be treated in the hospital as a tourist. So no problem. We just pay.
So the health insurance is incorporated into the government.
But it's not
Yes.
health insurance. There is
No,
a health
it's-
insurance, but that plays a really small role. But it's
Uh-huh.
publicly funded healthcare. So it's
Okay.
tax paid, controlled and paid healthcare, and no
Okay.
really insurance
So
there.
even even non-Danish taxpayers get the service then. Okay, very impressive.
Same in Sweden and Finland.
Maybe that makes it easier. That could be part of the different approach. So you don't have the competition, you don't have these discussions. So if the government has to provide a service, it's most likely more coordinated.
Yeah, I would say there's more dictatorship. So, but
Yes.
we still have some challenges with the reimbursement and payment structures because there
Yes.
are private providers and so on. But I would say that your situation is more tricky, and I understand that when it's been building decade after decade, there are so many compromises being made that nobody really wants to spread it all open and start from scratch.
Sometimes it's better to have a good dictator than a bad democracy. So the way I usually explain it, I say Switzerland fits about 10 times into California, and California is just one of 50 states. And we always have 26 different solutions. And in the healthcare sector, we have on top the doctors and the pharmacies who have their extra solutions. So it makes the world extremely fragmented in our environment. Yeah, Marcus, you wanted to say something?
Yeah, and there's one aspect more that is typical Swiss, since we have these different insurance companies and the state is very liberal and very private, and government does as less as possible. There is no data sharing, clinical data sharing between insurance companies and care providers. So the insurance just get the tariffs and the invoice to be paid, but does not know what the treatment was. And one paradigm in Switzerland is that there's a Chinese wall between the patient and his medical doctor and the insurance company. The insurance company has not the right to see any clinical data, any diagnosis of the patient. And this also is something that led to a culture where the medical doctor does not want that anybody else can see his data. There is no quality control, there is no outcome measurement, there is no value-based medicine, there's just a service, a fee for service. I go to the doctor, he does the monitoring of my diabetes, and he sends the invoice to my insurance company, and that's it. The result, the outcome, whether he does a good job and my HbA1c is okay or not, there's no checks and balances, there's no control. It's just me and my medical doctor that care about. And this is also characteristic, and that is also why data flow in Switzerland is a problem. Data flow between the different stakeholders of a patient or his disease is by culture a real problem, and that's also why medical doctors give a lot of resistance on political level in the parliament to advance, to bring the electronic health record forward. The opposition is mainly coming from medical doctors. They do not want to be transparent and visible and any quality control.
So what you described about the insurance company, that's the theory. In the practical world, it's totally different, because for the billing process, we have this tariff system, and behind every tariff position is a pretty clear treatment. So the only ones who have structured data are the insurance companies. So they have their internal departments. They're not allowed to share this information, but of course they are analyzing it. So the ones who really know what's going on are the insurance companies. And the other thing is what they are doing. It's called upscaling. Whenever in a hospital you have a treatment, the business model of the hospital is to add as many services as they can legally. And the person who are doing that are called coders. And the coders, they have very high salaries because they really bring value to the hospitals. So that doesn't reflect the reality of the treatment. And I have been told by a director of a hospital, they have this official formal exit report, so this mission report, which has to be signed by the chief medical chief or whoever does that. And then you have a totally separate track, which is the exchange of practitioners between the hospital, which reflects the medical and clinical reality. And these are two totally different things, which is insane if you think about it. And
here we go. That's it. That's what you're absolutely right. Insurance companies know very well, but on a political level, when you discuss data exchange, then we are living in this completely separated world with Chinese walls.
And I think there's a critical difference that Markus already made, and that was that, okay, insurance companies know what has been done. They know the performance, what each measurement and so on, but they don't know the quality that has been improved. They know this action, but not the actual results, because that's not measured.
They also know their black sheeps as well. So a colleague of mine was in one of these billing systems, and if a medical doctor reports 36 hours of treatment per day, then obviously something is wrong. So there are some quite easy checks, and the insurance companies know that very well. But they are
not just for the billing and kind of misusing that, but also for people with type 1 diabetes, for instance. Do they actually control how well the clinic improves the life of those people with diabetes and their values and so on? Most of the insurance companies, they just check, okay, what's been done and pay for that.
Yeah, there is a trend now coming along about this patient outcome measures, as you certainly know. So they realize specifically radiation clinics because they only have a very partial view, and they would like to know the effect of the treatment. And they never see the patients again. So they would be very interested in these type of patient outcome measures. And it's an increasing trend in Switzerland. So there are certain hospitals, University Hospital of Basel is quite good in these things. So they realize it's important. There are even more interesting developments coming along. One is P4P, payment for performance. So you don't pay for the treatment, you pay for the result. Then you have to measure the quality. It doesn't work without data. And even more interesting, the whole precision medicine is only possible with data. So it's a known fact that certain treatments and medications have different effects on different DNA settings. So in some configuration, it might make sense if you know the DNA analysis from a person to prescribe a certain medication. For others, it doesn't make sense, or you have to prescribe a different dose, and you only can do that with data. So I'm actually quite positive that with these developments that there will be a trend towards better quality data. And talking about these data topics, that was one of the key findings of Dr. Braum-Stiltjes of our December webinar. So he was looking for a digital twin of his own person, which he could take along and make it available to whoever is a healthcare provider and provide a service which benefits him as a person. So having the data with him and not stored in the silos of the hospitals and other specialized treatment agencies.
Now, it's just a comment about this effect. In our system, we don't have a good test and evaluation of data as in cardiology. I know there's a doctor who has made some research. He says there's only evidence for 7% of how good the treatment is. So they estimate that 20 to 30% we should improve by making better choices if we know the effect of the drugs. So we have a lot of system. Say if you have a drug on the market, you test it, is it useful or not, but you don't use it in real life testing. It's only in clinical research. And so we still need that track in Denmark, and because we might pay for treatment that is not having any effect, or even worse, they have harmful effects. So that is our debate right now in Denmark.
So having the data beside the clinical research, that was actually a big discussion about 2 or 3 months ago. There was an event in Basel, and on stage was Severin Schwan, the CEO of Roche, and he presented an interesting chart. It was a pie chart, and about 4% from the actual data came from the clinical research, and the other 96% of the data are so-called real-world data, which is coming from other sources which are not on the same quality level as from a clinical research, but you have a much higher volumes. We have some statistical balance. And his very big vote was, and he mentioned that in every other sentence, in Switzerland for the electronic health record, we have currently an opt-in solution, which means you as a citizen have to actively say, I want to have such a health record. And he was voting for an opt-out solution. So it's the Denmark approach where you get a health record automatically, preferably at birth. And if you don't want it, you have to say, I want to opt out. So that was his big vote. And the intention behind this was to get better data. And he's not interested in my personal data from Peter James, whoever has this data. The clinical research is obviously interested in the cohorts, in the volume. And his vote was to establish a system and an environment where we can collect this data in a better form, and of course in a structured form, not just PDFs with free text.
Thank you. My main message today was that there are kind of two flavors to MyData and data protection. And one is the one we know from German-speaking countries: don't store my data, don't share my data, don't even record my data. And the other one from Nordic countries is much more pragmatic and saying, let me choose where my data is being used. Do store my data, but allow me to control where it's being used. And I urge you to look at that point of view as well, because we do need the data to be processed.
Sure. My thoughts are on let's move away from evidence-based medicine and move to real-world evidence-based medicine and precision medicine in the future. That's the MyData way, and if we're in control, nobody will complain.
Data is key for a good diabetes care. So let's design solutions and services that fit with users' behavior and users' self-declared requirements, patient-centric, but let us establish systems that allows the data flow between patients and care providers.
I think we need a person-centered data integration with these intermediaries that can help you control your data for your benefit. And that will also, in the end, benefit the society and everybody around it.
Today, we focused specifically on the medical sphere, and I think it's a good example, but of course, there's much more at stake. And for Switzerland, I think there needs generally to be more awareness of what's going on. So more public awareness of what is happening in the health system. Politically, there needs to be more awareness. And basically, this is, of course, also where we come in as Swiss Data Alliance, that we want to raise awareness and leverage change in these parts. But I think, yeah, it's a certain mindset that has to happen first. It's a cultural shift.
Markus, in his presentation, referred to the Diabetes Excellence Center. So we would get data to doctors to be analyzed, specialized doctors to be analyzed. I would say already in 5 years, we should be further than that. In 10 years, definitely we should have just algorithms analyze the data and see, okay, these are the patients that are doing really well. These are the patients who have been doing well but are now declining. These are the ones that we should put the efforts on, and so on. So I totally see algorithms and later AI, even AI, helping us. And to get there, we just need to get the data available for the algorithms and the AI to learn how to behave.
I think that we will be at the point of active insights for all people living with diabetes. I also think that we will have vaccinations or gene therapies for type 1 diabetes within 5 years from now, as being part of the vaccination programs for the people with the right gene setup for that to work. So active insights for all diabetic patients. Share the data. Get the data flowing. That's the decision. That's what needs to happen.
What matters in the future are still quality and cost. And in order to get this aligned, we definitely need data and we need digitalization, and we have to start now to fill the necessary data lakes for applications as artificial intelligence and algorithms, indeed to improve the quality of care and give a better life to patients.
I think that in 5 to 10 years, I would like to have the freedom to share my data to get the best treatment. Somebody can look in my data. What do I think we decide today? I think we need a common consent model and also a payment model for all these stakeholders, because I think it's more a political problem than a technical problem. So I think that everybody needs to have a win-win system and not this the winner takes it all.
So I would say, since it was a rather extended session, we finish it up here. So from my side, thank you very much for taking the time for preparing all these insightful presentations, and we see each other at one of our next webinars. Thank you very much and have a nice evening.